wound management and aftercare. So as nurses, wounds, we are the bread and butter for wounds. Doctors aren't very good at wound dressings and knowing what to put on them. They always come to us and ask what to do. And the AED, I don't know about yours, but in the AED we have really crap dressings. We don't have very good dressings. Today we're just going to focus on acute wounds because that's big enough in itself without even going into chronic wounds. So we're just going to talk about acute wounds today. So this is what we're going to discuss. Function of the skin, provide an overview of acute wounds, impaired wound healing, because we still can have acute wounds that still have some impaired wound healing, but also you need to think about it for down the track. The wound might be acute that we see it, but it might be a frail old lady, so we need to think long term. About infection and different grades of wounds, topical antibiotics and oral antibiotics, dressings, and I've got some case studies and quiz at the end of it to make it a little easier. Just not a hard quiz, just a quiz that we'll talk about together. So first I thought, this follows on quite well from suturing, so I thought we'd talk about the layers of the skin first. So you've got different layers of the skin. So you've got your epidermis and dermis, which are one of your skin layers. Okay, then you've got your subcutaneous fat, which is that bubbly kind of looking stuff that you see. That's what subcutaneous fat and tissue is what we suture up. Then it doesn't have it there, but you have what's called a fascia layer. Okay, and that's just another kind of protective layer between the muscle and the subcutaneous tissue. Then you have your muscle and your bone. Okay. Now muscle, I always thought, oh, I don't know what muscle looks like. Is that muscle or is that subcutaneous tissue? They look quite different. You can tell the difference between muscle and between subcutaneous tissue. Muscle looks quite different, and you can't really describe it, but when you see it, you know it looks very different. So now I think there's a little bit of A&P here, but this is it. So phases of wound healing. I thought we'd better talk about that a little bit. So there's 3 phases of wound healing, and one doesn't start without the other starting. So there's a crossover, as you can see on the graph. Is that the wee light? That button?
Yep, should be. No, possibly not. Oh, the middle.
Oh yeah, right. So as you can see here, that first phase is inflammation. The next one is cell proliferation, and the last one is matrix remodeling. So you can see that they all cross over, and one does not stop until the other one has started. So inflammation, so this is the body's natural response to an injury. Okay, so this is what happens immediately following the injury to the skin or whatever it is. So what happens is blood vessels in the wound bed contract, and that's how the clot's formed, okay? And that's when you get your clot formed. So then you get homeostasis, and what homeostasis is, and that means the bleeding is stopped, so that means bleeding stopped. Once that's been achieved, the vessels dilate, not bleed, but the other vessels dilate, and they help special things come into this, special cells come into the wound, such as enzymes, antibodies, white blood cells, nutrients and things like this, and that's what causes the exudate in a wound, okay? So all these things come in, and these are the things that help the wound healing process start. But that's why you get the exudate. It's all those things coming to the area of the wound. And often when we see patients, so you know infection doesn't start until at least 48 hours after. So if you see a patient that comes in one day after an injury, and they go, oh, I've got an infection because I've got some little bit of redness and some fluid. Well, the fluid is just all those cells and stuff coming to help with the healing, and the redness is just inflammation. So it has to be at least 48 hours until after the wound has been, injury has occurred, that infection can start. So you always know that it's going to be inflammation generally. Okay? You can also, with inflammation, get heat, edema, pain. That's just really normal as well in the inflammation stage. The next stage is called proliferation, and this is where the wound is rebuilt. Okay, so this is when the new granulating tissue starts to come through. And it's made up of collagen and a few other bits of cellular tissue, and that helps fill the wound cavity or the space. Okay, and what happens there is they network between the blood vessels, and this is known as angiogenesis. Big words, I promise And what happens there is this granulating tissue, it often, it builds at different stages. So you know how you get that funny, uneven, when you have a scab, you have a funny, uneven, scabby tissue. That's really normal because what happens is it granulates at different phases and different stages. So that's quite normal. So a good sign of a healing wound is pink, really nice and pink and warm. A bad sign is dark brown and red in those early stages, okay? So once that happened, the epithelial cells finally resurface, and that's when you get epithelialization. Can't even pronounce that word. The last phase, okay, and this is the maturation, and this is where the final phase, where the wound is closed up. Okay, the phase involves remodeling of the collagen and reduces the number of blood vessels that are there, because what the blood vessels were doing, remember, they were expelling all those cells to help with the wound healing. But the thing you need to remember is, with big wounds, it can take up to 300 days for a wound to fully heal. So that's why often after I take sutures out, I put steri strips on, okay? Because what happens is, even if it's for the 14 days, you get the keloid on high tension skin. So whenever you take out sutures, you should always put steri strips on, okay? Because they often will pop in those high tension places. So that's the horribleness page. So principles of wound management. So what do we want to do when we see a wound? What are our main focus? What do we want to do? We want to heal it? Yeah, exactly. That's the end result, isn't it? Okay, but we want to also identify the cause, okay? Because we want to know what happened, because like we said in suturing, it can be quite different to how we treat a wound. Also, we want to reduce or eliminate causative factors. So if they've got, diabetes, if they've got PVD, we want to make sure they're on the, diabetes is stable so that they're healing as best as they can for a diabetic. So we want to just look at their history and make sure we can remove any causative factors. Or if they are self-harmer, we want to make sure they don't do any more cutting whilst we're getting at these other wounds to heal if they're in our care. You want to select appropriate dressings and topical therapy, and you want to plan and implement an individual plan for that patient. Okay, obviously in ED we aren't able to do all that, but what we might do is refer to district nurses, or we might refer to GP, or we might get them back for another wound dressing. So that's implementing some changes, some stages for the patient. We want to know that the wound is going to heal at some point, even if it's not just, with us, that they can follow up and have good follow up with that. So wound and wound injury assessment. So it's like suturing, you need to, mechanism of injuries, we need to know the medical history, any medications that they're on, which might influence their healing, any allergies that they've got. Obviously explore the wound, make sure there's no nerve, tendon damage or bone that can be seen. Want to make sure the vascular integrity, if we are going to suture it, that it's going to heal properly, because obviously not all wounds are going to be able to be sutured. ADT status and foreign bodies. So for impaired wound healing, like I say, at the start what we do is we, are just dealing with the acute wounds, but often they're going to be a chronic wound. We'll get someone from the initial injury, an X-ray, do everything, and know that there's going to be problems down the track. So you need to think about that. So you need to think about, like we said, localised edema. If it's a crush injury, they're going to take longer to heal, so they might definitely need district nursing follow-up or GP follow-up. Edema, so if they've got PVD and they've got edema in the legs, they're going to be delayed wound healing, aren't they? Infection foreign bodies, if they've got comorbidities, if they're like a paraplegic or obese, it's going to cause problems. Medications like steroids or anticoagulants, if they've got nutritional deficits, if they're a smoker, that's a really big one as well. Or repeat trauma, self-harm. So there's 3 stages of wound healing. So who knows what primary wound healing is? No?
Just the initial part of doing it.
That's us closing it.
Simple.
Yep, so that's like suturing it up, and that's, or steri-stripping or glue, that's the initial closure of the wound within 24 hours, okay? Secondary, yep, secondary intention, yep, just letting it heal, so leaving it open. Often we'll do that in the elderly, or if it's, I had a really nasty bite lap the other day, and it was on a hand, and the orthopaedic doctor said just to leave it open, not to suture it at all. And then there's the delayed wound closure, so for contaminated infective wounds that are left for approximately 48 hours. So I've given you guys all a wee handout about this time. So I caught up and done a lot with Mandy Pagan about this, and she was really helpful, our wound specialist at SDHB. And she talked a lot about this time that they use, and it's been quite a new thing that they've used. So I've given you a wee handout that you can keep. So what the time means for the tissue, you need to look at the tissue and is it viable or non-viable. If it's non-viable, cut it off. So don't feel bad about any skin flaps, any crusty edges, anything like that, just cut it off. Obviously localise it first because it might be a bit sore, but if it looks dead, you'll be able to just cut it. Because it's not going to heal and it's only going to cause more problems, so you're best to cut it off. Often you need to cut off extra subcutaneous tissue or skin to help bring it together as well, so don't feel afraid to cut any skin off. Then you've got your eye for infections or inflammations, and what that means is simply remove the infection if you're able to. If it's foreign body, if it's infection, give it a good wash out, and you need to look at your antimicrobials and antibiotics, okay? Your moisture, so we were talking before in suturing, keeping it nice and warm at about 37 degrees, because this increases epithelialization rate, but you don't want excess fluid, because that causes maceration and drowns the wound, and you go back to square one. So it's sometimes a bit of a hard balance with getting them at that stage. So when I talk about burns, that's a really common one for that, so we'll go through that. Blisters, sorry. And the edge of the wound. If it's non-advancing, why is it non-advancing? You need to go back to the start and see what new therapies you might be able to put on it, or what the cause might be why it's not healing. So, completing the wound assessment. So, even when they first come in, when I see a patient, you need to document a wound so that someone can see it and visualise what the wound is. So, because we often have people come back, and what patients might say is totally different to them. Oh no, it's a lot worse, when actually, you know what some patients can be like, or they say it's a lot better and it's actually a lot worse. So you need to be able to let someone else visualise and know what they're seeing. So wound dimensions, how big it is, okay, is really important, and the wound colour is really important. So I've got some pictures here. So you've got your necrotic black, so that's always low exudate, okay, because it's a hard, solid necrotic edge that doesn't allow generally any fluid to get through. These need to be rehydrated, okay, these need to be broken down. You need to get rid of that necrotic tissue, okay, and that, because you're not going to get any more healing. That's just going to stop there, and you're not going to get onto even the basic inflammation stage because there's nothing there to get out. Next stage is slough. Okay, that's quite gross, but you need to get rid of that. You need to wash it down and get rid of it, because again, there's too much exudate and you're not going to be able to continue past the inflammation stage for wound healing, so it's not going to get any better. Then you've got this stage which is granulating, which is good, which was where we're wanting to get to. And what happens here is this, once it's at this stage, to assist to promote granulation, you need to keep it nice and moist. Okay, so they keep going on about this moist wound bed. And then last is pink, which is epithelialization, which is the last stage, which is when we're going to be getting some wound closure. Okay, so you need to just remember that these are the 4 stages. Generally, we don't see these in EDs. These are more probably chronic wounds, but I thought I'd bring them up because sometimes we will see them in ED, and know that you need to get rid of all this muck here to be able to get onto these stages. Okay. So then you've got grades of wounds. Have you guys heard about grades of wounds before? See, I'd never heard about this actually, so this was something I learned. So grade 1 is just like cellulitis, like a basic erythema cellulitis inflammation. Grade 2 is superficial loss, so it's like an abrasion or a small cut on the part of the body. Grade 3 is where the epidermis and dermis and subcutaneous tissue has got a formation, so that's just like your lacerations that we've been dealing with this morning. And then grade 4 is where you've gone right down to the bone and tendon and you need specialty advice to help sort that one out. So that's your grades of wounds. So infection. So this was quite good that I learned that approximately 15% of all acute wounds potentially will be contaminated. And that is not including surgical incisions though, that are done in the operating theatre. So think of that when you're washing out a wound, that you need to wash it out and do you need antibiotics? We tend to not really give antibiotics, it's more on the washing. But just remember that, yeah, 15% of wounds will potentially become infected. Ensure that you've debrided the wound right back and trimmed the edges, because those macerated horrible skin edges can cause infection and can cause problems, so you need to get rid of them. Irrigation, like we talked about before, really important, and heavily contaminated wounds will require antibiotics. Topical antimicrobials is not something that we really use in ED. So when I spoke to Mandy about these, she said she doesn't often use them either though. She said you've got to be really careful on what you use them on, because what happens is wounds, one, if you try something, you don't know if they're going to have an infection to it. She said some have bacterial resistance, so when you go actually to try and use antibiotics, it causes problems down the track. So she said when she does use them, once the wound starts to heal, she stops them. So they're only used very minimally, and if there's no improvement in 2 weeks, they need to be stopped. So they're not used very often. And I've just got a couple up here that she uses, and they're just for your information about what you'd use them for. Okay, but I am going to talk about iodine, like I did earlier, that you should not use it to clean wounds because it just delays wound healing. Okay, so don't ever use, people often sometimes will water it down so it's not as harsh. It's still not good. You just shouldn't use betadine or iodine. The other thing I'm going to talk about is SSD cream, which we use a lot for our burns patients. Something I learned is I didn't realise, I thought you had to change it every 24 hours. You can keep it on for 48 hours. The reason why it needs to come off after 48 hours is because it can cause a film, and it's hard to get off and it's painful. But she was saying she puts SSD cream in actual cavity wounds, not just burns. Yeah. And she said it was showing, research shows that it helps decrease the bacteria. So, SSD cream is this flamazine cream that we use on burns. Yeah. So it's something that you use, helps keep moisture in, and is that the full name? Yeah. So we use it on burns, but she said they're starting to use it on actual wounds. Not that we would do that, but you can do it 2 days, she said, even for burns. So but the thing with burns is you need to initially get them back every 24 hours because of the risk of maceration with the fluid and things. So
I see the Olivia she's got, or you have got, iodine should not be used on non-infected acute wounds. However, she used to use it in VACs, like she would put.
I don't know if she uses it anymore.
Yeah, I'll be interested to know if she's just wiped it.
Because this is information from her actually, and research shows when I was looking up stuff that that it did show that there was a decrease in the bacterial cells, and it was showing to cause more infections down the track rather than so it shouldn't be used. So now we're going to go over some basic dressings. Okay, so these are things that we will possibly use in ED if we had a great storage. So this is our basic stuff, our MOV019 oxides, techoderms that we use, okay? So they're mainly waterproof, they're pretty good. They create a moist, warm environment for healing. They're a barrier to bacteria, so they don't let anything in. The thing is, they're non-absorbent, these plain techoderms. So if you're going to have a bit of an oozy wound, they're no good. You need to use either the MOV019 or the Opsites with a pad in them. It's normally a primary dressing, but it can be used for a secondary as well. So what I mean by that is the primary is just when you have one dressing just on the skin, or it can be used as a secondary if you've got a cavity that you need to cover, have another dressing underneath. And it's genuinely gentle on the skin. MOV019 not so much, but it's genuinely pretty good on the skin. The foams, which I really like, and we don't really have them in ED, which I think we should actually. But these can be used as a primary or secondary dressing as well. They're comfortable, they're easy to apply, they're not harsh on the skin. You can get the ones that are sticky or the ones that are not sticky. And then you just use them, put a Tecadrim over top of those. The one thing that I didn't realise is the wound dressing has to be 3 centimetres greater than the dressing. So you've got to make sure that there's a good circumference so it gets a good seal. That's I think why, because I suppose there's a bit of there's the foam, and if you don't get a good seal around it, you're not going to get a good seal around the wound, and bacteria will get in. And cavities should always have a primary dressing, so if there's a cavity you need to have something else underneath, which I'm going to go through now.
I don't think we have those back. You know, we have taken them away from the whole hospital.
Oh, the whole hospital?
Is it from 11?
11, yeah.
It's also using that MOV019.
Even from surgical?
But even since gone up at home as well.
Yeah.
It's so expensive.
But they're great, aren't they?
They're fantastic. What MOV019
Wow.
there was other MOV019 dressings that she had.
Oh, is that new lady that was here the other day? Right.
Is that including that blue stuff? What's that?
So I've got some blue stuff.
No, MOV019 is that one. No, the soft one with the sponge and the blue.
Oh.
It's like a bluey, but it's absorbent. Yeah.
Oh.
Yeah.
Yeah,
Yeah, something like that.
it absorbs.
Yeah, but you take on.
Yeah.
Yes, it'll be interesting to see what happens. Calcium alginate, so this is like our algicite, our seaweed dressing. Now, I don't know if we have that even. We've changed.
We stole it from the wound clinic.
Oh yeah. So algicite rope is really, really, really good for wounds. So what happens with this, it forms a soft gel when it's in contact with wound exudate. And so what that does, but it still remains intact. So if you put the ropes in, you can still pull the whole rope out, genuinely, normally. And you can pull the whole rope out, but it soaks up all that exudate and that muck and helps improve wound healing. So it's really good. The other good thing about it, because it's a long rope, you can put it into a deep cavity wound without knowing where it's going, whereas you should never put gauze or anything into a wound where you can't see where it's going, because gauze has been left in wounds before. So something like this rope is really good. So it's good for moderate to high exudate. Like I say, it draws out all that exudate with maintaining the wound, making sure it's nice and moist. You can have it for larger wounds, deep cavities, and it doesn't adhere to the new granulating tissue, which is another good thing. So you know how sometimes stuff sticks to it and you pull off that really nice new wound, granulating tissue, that doesn't do it. And this must have a secondary dressing on top, you can't just have that on its own.
It's good for paralysis.
Yes, it is, yeah. So then you've got your hypofibers, like your Aquacell. Now we have this. Or have they taken that away too? We did have it, yeah. We did have it. So it's made up of the sodium, I can't say that last word, but what that does is that converts to soft gel as well. So it's a little bit like your calcium alginates that we had up before. Again, it continues to keep a moist, warm environment that helps get rid of some of that heavy exudate. So that's really good, and again, it requires a secondary dressing. And then you've got your hydrogels, sorry. We don't have this, but it's great. It's because it's the same product, obviously, as the 11. It's made by Smith and Nephew. So again, this stuff is awesome at breaking down hard necrotic tissue, and it's optimum environment for epithelialization, and it has less, research shows less scarring. You shouldn't put it on healthy skin, just in the cavities where it's required, or the necrotic skin, but It's a shame because that stuff's really good too. The last one I'm going to talk about is MOV019 because now that we have that in the department, and it's really, really good on lots of different wounds. So it's a gentle adhesion and it's made up of the flexible polyamide and silicone, and it's a silicone that helps it not stick to the wound, okay? So it's really good and it helps because it's made up, it's like a netting, it's like the Cutiserum a little bit if you haven't seen it, and the exudate is able to come through the dressing. That's why you should never double over the MOV019 or Cutiserum. You should always just have one layer, because if you double it over, what happens is you stop that weaving to be able to let the exudate come out. We frequently use it for finger lacks, crush injuries. You can use it on burns, blistering and grafts. And they use it on grafts actually that they, like skin grafts that they do when they, and put it on the host area. Again, it prevents maceration and it helps wound healing and removes the exudate. And it can be removed without pain. It lasts up to 10 days. You can reuse it. You just put it on normal saline on. So what people do is you take it off, look at the dressing, put it back on. That's great. And that makes it more cost effective, of course. So.
When can you put it? How soon can you put it on the secondary rooms?
Straight away, I presume. Yep. Any injuries straight away. The other thing that Mandy gave me, which I think would be great to get the department, but Smith and Nephews may not. What it is, it's a cleanser, and it's really good.
We've got it.
Oh yeah, and what you do is it cleans, I've never seen it work actually, but it cleans the wounds. It's sterile, and what it does is it cleans, conditions, moisturises and protects all the surrounding skin. So you just spray it on and just rub on the surrounding skin. It can go into the wound as well. And that's once you've like washed it, and then you just leave it on. It doesn't sting, it doesn't do anything. So
I've seen the bottles, but you never was just
No, but you see that sometimes, and you've got people that have got starts to get a lot of
sorry, it looks great. Nancy uses it all the time. So here we go.
skin.
Well, first year, one thing somebody's been using on a big year.
Because it's the same stuff.
It's aseptic. In the bottle it's sterile, but it's aseptic.
Yeah.
It's also very sterile.
Oh, okay. I was going to say, I have this.
Yeah, aseptic. Yeah.
So it's not very stuff.
Yeah, that's great.
So you
Yeah.
can't throw it in spin it.
Oh.
It's great. Around their houses and stuff.
Yeah. Oh, yeah.
Yes, it's smell. I've just seen it, I just didn't know what to use it on.
Yeah.
So yeah, it's really awful.
I think it's surgical when you used it for once, but I did use it
I've seen
for
it.
incontinent people.
Oh, for like rashes
And
and
they're all
stuff.
excoriated, so we clean them with that, and then there's a cream that's in the matrix that matches there, and you plaster that on, and it protects them. So it must be able to use it.
Yeah, so I've never seen it or used it. Yeah.
Use the trophy.
Do you get about rashes?
No.
Cleans this, moisturises this, properties.
Yes. I don't want to know where that's going.
Yeah,
Girls.
How is that actually quite innocent?
So it says here that it's a one-step cleanser for the body and perineum.
So, the products of principles, what you need to do when you're looking at a dressing or whatever type of dressing you're going to put on, ensure that the patient has involvement and explanations of that. You know, if you put a wet let go, that's all that needs, you know, and explain why it only needs it. Or if it needs something more and you need to get them back, explain why. You need to protect the surrounding skin, so make sure it's not going to get macerated and get all start breaking down, because the last thing you want is the healthy skin to start breaking down. Aim for moist wound healing. Identify the aim of the treatment, so using that TIME acronym. Have realistic goals. If it's a laceration that's pretty clean cut, you know, say, or we scared that it is only going to take 10 days, or if it's a deep cavity, say it could take 3 or 4 months, you know, let them know that it can take time. Avoid adhesives on fragile skin. Well, we mostly know that. You know, you want to make sure that you don't put a hard, tacky fix on this poor fragile skin, sometimes you just need to use paper tape with the dressing because the other stuff's even too hard. All cavities need filled, okay? Even if it's gauze, as long as you can see it and you document, you can put those in. But if you can't see where the wound's going, you can't put gauze in because you don't know where they're going. That's that bit there. And yeah, large exudated wounds will need more frequent changing. Okay, so sometimes district nurses need to go twice a day for some wounds, you know, so think about that when they come in, that, oh, they might need district nurse tomorrow, or it'll be right for 3 days, or whatever. Try and think, because the last thing you want is the wound start breaking down.
What's your criteria between using a wound clinic and district nursing?
So you always generally go district nursing first for our wounds that come in. If it's a chronic wound and it's something that's been ongoing and not healing, you can refer to wound clinic. You just put but you need to do district nursing first because wound clinic takes a while to get to see them. Okay, so, and often the district nurses and Mandy have really good relationships, so what happens is, if we say we've put something through, then what will happen is the district nurses will talk to Mandy and they will talk between themselves and sort it. Yeah. So now we're going to talk about the types of wounds. So this, what's this? Pardon? Yep, basic laceration. Yep, exactly. So it's just a basic laceration trauma. So something like this would just require a good, if it was just something clean, just a good clean out with some normal saline, and suture it up, and then a basic dressing on it. Because once you've sutured the laceration, bleeding should stop. Okay, so generally something like an oxide or MOV019 is really fine on something like this. Obviously, if it's a wound that was a bite or something, you're going to go down a different track, and they're giving it a good, really good wash out. But something like that just needs a basic dressing.
So would you just do a standard?
Standard suturing and then standard like MOV019 or oxide on that. Yeah.
Do you not deep suture there?
That one there, I can't really tell how deep it is. Depending on how deep it is, if it does require deep suturing, yeah. But
We would.
yeah. Yeah. So yeah, the dressing would just be a basic dressing, nothing too flash. Sometimes even just a gauze and a ticketer, you know, as long as you've got a seal, because obviously the wound is still opened. You know, even though it's sealed, there's still an open wound there that infection can get in. So it just has to be something that covers and causes a barrier to the skin, okay? So, surgical wound. If we had someone come in like this that needed a dressing change, which we sometimes do, what would you put on that, do you think? Yeah, something like that. Often we get people that come in and want them.
Not with the. We just take the tiny wee oxides.
That's why you use that one.
We don't get the bigger ones, the long ones.
Sometimes I'm running surgical, but they don't do it. Can we just make them with your
You can do
and
it
bristles?
because they use end to end.
Yeah.
The other thing is, if this person had these staples removed, it was at, say, the 14-day mark, what do you think you'd do once you've removed the staples? Steri strips, yeah, because it looks a fairly significant size wound and it's just going to pop open, isn't it? Because it takes so long for things to heal. People don't realise, they think once it's sutured up and you've taken sutures out, it's going to be fine, but it's not. It's still got another probably 2 months of healing to do. Next one. Right, now this one we're going to talk a bit about. I know Lara went over burns yesterday. We had a bit of a discussion about this. But traditionally blisters, you'd leave them, okay? And so it's only in the last 2 years that Mandy said they've changed the outlook on blisters. Blisters, you would normally just cover that up, leave it, let it pop naturally. Now research is saying, which makes so much sense, that we are to pop them under an aseptic technique. Burns blisters, blisters that have been formed from on the foot from, say, rubbing, anything like that needs to be popped as soon as we can see them. Because what's happening is, if you leave this, and what happens, it's painful having blisters that are fluid filled, and the gel under the fluid under there gets really macerated in gel if it doesn't end up popping itself. And what happens is then it's really hard, it just delays wound healing really. So what happens is you need to, when you see something like this, you need to just get a scalpel, like a little scalpel or blade, and make an incision down the side. It needs to be a fairly good incision, because if you only make a small one, it just heals back up and seals back up and the fluid fills back up. You need to make that incision along there, push out the fluid, and then push the epidermis to the dermis, okay? So what happens is the fluid is filling, and it's in between the epidermis and the dermis that that fluid fills. So you're not going to get any healing, are you, if the skin and skin aren't touching. So once you've made that laceration, push all the fluid out and push the epidermis to the dermis, and then it just looks like skin. It's just skin on skin. You then cover it up, but you need to remember for up to about 48, 72 hours, blisters, burns continue to fill. Okay, so you need to make sure that they're back within 24 hours. You need to get them back within 24 hours, because the wound, or they can get district nursing or GP, because that wound dressing that you put on is going to get macerated and wet, because it's going to continue to leak. Okay, you want that, you want the fluid to keep coming out, but you want the dressing to be changed, because you want that surrounding skin to remain healthy. Okay, so once you've done that, the healing, Mandy was saying, starts immediately, rather than having to wait. Okay, even with the fluid still coming out in that first 48 hours, the dermis is still on the epidermis, so it's just not delaying that wound healing, and it's showing that things are healing a lot quicker. So now, obviously you can't do it under sterile, it's just going to be an aseptic technique that you do it under, okay? So, but this is the plan for burns, and I'll pop them, okay? Then what you do, what would you do after that, after you've popped it, and what, would you put anything on them? What would you put on? SSD cream.
What about when you move next time?
So SSD cream, because it's an acute, if it's an acute burn, still put the SSD cream on, okay? And I was always under the understanding that you can put SSD cream on wounds, like, you know, you always just have to put it on the erythema, but it can be on wounds, but you just have to be careful, because the fluid will be coming out, that you don't make it too wet. But you need the SSD cream on that erythema, because that keeps moisture in and helps prevent further blistering, okay? So you do need to put that on. And then something that's going to soak up the exudate, whether it be a few gauze, because we don't have leave-in or anything like that in the department, to help soak up that exudate and then get them back for a revisit. Any questions about that?
What about the laser you do with that new burn stuff?
Yeah. Yes. So you can, yes. So
that on instead of the SSD.
I don't know whether you put it on, because the problem, I don't know whether you put that on. That's something I can't answer.
I thought we were using the fluid, so
Yeah.
Oh right. Well, at the moment, it's still being used.
Sorry.
I don't know about the because the new lady was here last week, was it?
Yeah, it's got the silver base in it.
Yeah.
Yeah.
So so that new stuff they may be using, yeah, but I don't know when that's coming out. When does she think that's coming out? Oh, have we? Well, maybe that's something that you're in charge of burns, aren't you?
Lara was from it yesterday.
Yeah. So maybe that needs to, SSD creams needs to be removed so that people don't use it. Oh no, it is. There's heaps in the fridge. Yeah.
Perfect policy.
Yeah. So maybe that needs to be removed, and then some education about that new stuff that is going to be coming in. About that, and then so that's that stuff like the Mepital kind of stuff that.
Because it's fine, but it doesn't stick.
Yes, yeah.
That's what they do on purpose.
Use up the old stuff.
The seaweed out, just like that would be put on there too, isn't it?
Yes, because exactly right. Yeah.
But not stick.
Stick. Yeah. Hematomas. So we see this a little bit with little old ladies that come in. I had one a wee while ago. It was only a little one, not as big as that, but. Hematomas, the key with hematomas is you need to get rid of the hematoma or the clot, whatever's sitting there. If it's a little one, you can do it yourself. If it's something like this, you'd need surgical intervention. Okay, you need a surgeon to come and do that. But the problem is, if you don't get rid of it, it doesn't heal. That granulated tissue doesn't come through. So you need to get rid of that hematoma. Okay, and like I say, if it's large, you might need a doctor. It will be painful, so the patient will need pain relief, Internox, something like that, because it will be very painful for them. Infected abscesses, we see this a lot in ED as well. Okay, thing with these is they need to be drained. That's not going to be fixed with just antibiotics. You can tell that it's just about coming through the skin already anyway. So you need to localise the wound and incise, but the thing you need to realise about putting local anaesthetic into abscesses is that abscesses, with the pH that they are, local anaesthetic doesn't always work. So you can localise and localise and localise, and they can still feel it. It's to do with the pus and the pH, and it neutralises the anaesthetic, that's what I was looking for. It neutralises the anaesthetic somehow. And that's why they don't often do Bartholomew cysts and stuff down here anymore, because it just doesn't work. They need to be knocked out. So just remember, if you do drain that, often I use Internox as well, because they can often be quite sore. And once you have to make a decent laceration, and you need to do it over the most point where you can feel the fluctuation of the muck, okay, which means where you can feel the pus and the most top point. Often you can see it coming through. Make a decent maceration that wound then needs to be milked. So what? So you need to get out as much of the crap as you can, okay? The other thing you need to remember about these is you need to put a wick in them, because you don't want the top healing over and the underneath cavity filling again. So you just cut one bit of gauze only, as a ribbon, and put it in and have it poking out the top so that the top doesn't close over.
Would you use topper cages?
Yeah, you could try that. That would be really good actually.
Yeah. Local, because
yes.
It's
only to the skin. Yeah. You know, that's a really good idea. Yeah. Pardon?
Someone else's.
And this is a skin flap. We see this quite a bit in ED. The little old ladies that have walked into something and didn't even feel it, and then half their legs off. With these can't be sutured. There's no way you can really suture this. The skin's far too fragile and the edges are too macerated. So this often, you can't even often sometimes series strip these. Sometimes these just have to be healed by secondary intention. And the unfortunate thing is they're old, they've usually got 100 medical problems, and it's going to take ages to heal. So these need to be referred to the district nurses, and they need to realise that they need to have their feet up, that it's going to take time to heal. And if they're immunocompromised, they often will need antibiotics as well, even if it's a clean wound, they will. So now we're just coming to the end, so we're going to have some case studies, and what I want you to do is tell me how you would treat this. Irrigate, yeah. And yeah, so the thing with this wound is, dog watch, you don't know how deep it is, so you need to make sure you inspect well and make sure that you check the neurovascular obs. You need to make sure that you inspect, see if you can see any tendons or anything like that, because often dog teeth can be quite long and you actually don't know how far they've gone down. Another thing with teeth is you've got to be careful. I had a patient, a wound, that he was playing rugby and he got a laceration, didn't know how it was, and there was actually half a tooth in his face. And you've got to be really careful about foreign bodies. And I don't know why I x-rayed it, but luckily I did, otherwise I would have stitched a tooth in the shape on me.
Simon Brooke, he said if I find a sharp tooth.
Yes. So you need to make sure that this is really cleaned well. These, I talked to Adam about it too. We sometimes suture these. He said it's best to do delay suturing, but he said often we will just suture them and give them antibiotics if we've given them a good clean out. One, because it's easier for them and give them antibiotics, but you need to just make them aware that there is a chance of infection because of the injury that it was. So, does anyone know the most infectious bite? Human, and then dog. Yeah.
Then shark.
Then shark.
And you don't suture them totally, do you?
You what, sorry? It's in open, yeah, you leave it open slightly, yeah. So this was a laceration with a knife from a Meatworks guy. So what would we do with this one?
Inspect it.
Yeah.
Ask him what he was doing, what he was cutting.
Yeah, what he was cutting exactly.
You also need to know what size and shape you want it to.
Yep, that's another thing, because you're quite right, because those bony knives are actually thin and long. And what happens is it could be a lot deeper than what you think it is.
Yeah, explore it.
And we'll wash it out. Would we give antibiotics if it was just a carcass, not the inside? No. So the tending, like we say, steer away from antibiotics unless really needed. And then that would be stitched up, wouldn't it? And just a basic dressing on that. So this is a skin flap tear. What do you think you'd do with this on an elderly person?
Depends how thin the skin was, you might be able to do stereo strips.
Yep, so stereo strips would be quite good for this, wouldn't it? Because of the shape of it. You're obviously not going to get it fully inverted, the edges, there's going to be a bit of a gap. But if you can bring it over as much as you can, then that's probably a good thing. Do you think you might try some glue on that?
No.
Wouldn't that wee bit just dry and die, since it's so thin?
But you can try and save it, because often that skin will be saved, depending on the person, but you should always try and save first. So if you stereo strip that, you're quite right, whoever said no, I probably wouldn't use glue on this, just because it's probably going to cause more damage than harm on the fragile skin. Because often these will come together quite well. They'll have a bit of a scar, but it's better than leaving it right open. But because you've got it directly onto the subcutaneous tissue, it should take and it should heal like a bit of a graft. And what about this?
Pop it.
Would you pop that though? What does that look like? Looks like a colonal sinus, doesn't it? So now we're advised not to do
We would
this.
still pop it because we want to squish the stuff out.
So we've gone away from doing this in ED like we used to, because something happened and someone lacerated some bowel in a young boy. It was done by a surgeon too. But now, generally,
Fun and deep was he going?
it was a junior wedge.
How?
But anyway, what happened was, yeah, so even if it's bulging like that, you don't know how deep the cavity goes, and often for the polynidal they go right down, and so you need to, what they need to do is be opened wide in theatre. But dressings for this, if you're a theatre nurse, what would you dress this with?
You put the algae packing in it.
Algae rope, algae rope, yeah, that's what they use on those, and they pack it, and then have it wick out, and the district nurses do that for God knows how long, because they take ages to heal
There's
these.
a guy that can. Who are you getting on there? The guy that was doing it. And he.
Oh yes, I was on with you. He blood will through it.
Yeah. And actually he ended up being sutured.
I've seen them, and there's when somebody's having, you know, some people have them dozens of times over.
Yes, yeah.
They lay them open in surgery, and sometimes they can have so many different tracks, so they put in a dye that shows all the tracks,
Ah.
and then they wash them all out so that they're completely clean, so that they're not just concentrating on one, they get the whole lot, and then they do it right from the bottom and then suture it.
That's quite cool.
Yeah.
Not cool for the patient,
No.
but
I've never seen one of them when I was a student. I was on district nursing my first day at 8 and 9.
Oh,
Yeah, but I was only a student.
it's often men get it, and it's often sweaty, hairy men that
Yeah.
get it. Because the sweat and the hair it starts really from like an ingrown hair, really. That's how they start. So,
Turkish kebabs. I said, don't even buy Turkish kebabs in this town. That's where you were going tonight, wasn't it?
Just who's here is sweated?
The Turkish
Oh.
kebab.
Right. Yeah, so the thing, I suppose the key you need to remember is with the dressing, long term, even though when they come into our departments or GPs, often they're acute, but you need to think long term about what is going to happen to this wound in time. Does it need follow-up? Does it need antibiotics? Does it need specific dressings and things like that? Because it's quite hard in ED, because we just see the forget the phase and send it on, and often forget about what's required. So you need to think about all of that, and that's it. Any questions?